Once I'm in. Okay.
Okay, I think we can begin for now. Thank you everyone for joining us today on another lecture / talk on our clinical series. Today we have with us Dr. Marta Horáková, our very first role models in medicine guest speaker who is joining us today once again. Thank you very much, Dr. Horáková, to talk about trauma surgery and mass disaster medicine. Dr. Horáková is a graduate of the second faculty of medicine here in Prague and is a double board certified adult and children's surgeon. And she's currently the head of the surgical department at the PSEC hospital here in Prague. We are very, very thankful to have you, and it's an honor to have you once again. Thank you for your time. Thank you for your energy. And without further ado, I don't want to waste our time at all. We can begin our lecture if it's okay with you.
Well, thank you very much for the nice introduction. I'm really honored to be able to talk to you like this. Please excuse me, I'm from the generation before you, so I might have some technical difficulties, but I'll do my best to deal with them. So I'll start the lecture. Before I start, just tell me, are most of you like final year students, or are there younger students among, just so that I know what level I should consider?
I think there's students from all years, from first to sixth year. I think maybe we even have some students from maybe specialization years. So I think it's as generic or as interesting as you want it to be.
Okay. If you feel that it's easy or it's incomprehensible or it's too fast or something, don't feel free to stop me. And of course, since it's online, if you wouldn't mind switching on your cameras, it would make it a bit easier for me so that I could see your faces and I can interact. But of course, it's up to you. So I'll try and share my screen with you. And can you see it? Trauma surgery, is it visible?
Yes, it is.
Okay, that's good. And I will try and play the okay, so thank you for the lovely introduction. I am a general and pediatric surgeon, and I have worked in MUDr for nearly a year and a half, which is a trauma center. My hospital now isn't a trauma center, but we do have isolated trauma here, and sometimes by mistake, we sometimes have patients with severe trauma. So it's like general knowledge for every surgeon, and it's also a little bit of a personal hobby of mine, mass disasters and trauma surgery. So let me see if I can start moving the slides. Oh, correct. So the lecture is basically going to be, I'll try and give you some interesting information, but we have to do some theory as well. So I'm not an orthopedic, so I won't be talking about fractures. That's not my specialty. In some countries, they're joined together, surgeons and orthopedic doctors, but here in our hospital, it's separate. So I'll be talking mainly about the thorax, the abdomen, and then I'll mention something about damage control surgery, which you will need in the treatment of hemorrhagic patients or septic patients. It's a universal law, I could call it like that. And then I'll mention a little bit about disaster management. So that's so that you know what the lecture is going to be about. So the first thing is we have to define what the trauma is. Trauma is an injury to a living tissue caused by something from outside. Trauma is also a surgical trauma. That means if a patient has an elective surgery cholecystectomy or appendectomy, that is also trauma. So the pathophysiological or the mechanisms that are initiated by trauma are the same as by elective surgery. It's the same type of damage, and that's why sometimes after elective surgery, the patients react in a very similar way as they would if they had an accident. Now, something that we define as high energy trauma are injuries that are caused by a very large kinetic energy, which is transferred to the body and induces great damage. So that's why I always stress to my students that medical history is very important, because when we ask the patients what happened, and you can see that the pictures illustrate really dramatic things, but they don't have to be so dramatic. In our country, the most common are car accidents, but of course falls from high places or war injuries. And it's always important to ask your patient how fast, how high, what happened, what was your speed, were you wearing a seatbelt, did you have an airbag, because this gives you some idea of what the kinetic energy was. Somebody who's driving 10 kilometers per hour will have a different type of injury than someone who's driving 100 kilometers per hour. So I consider, if you have time and if it's possible, and when the patient is brought in by the ambulance, emergency ambulance service, these are the information that you need. For example, what's also important is if the patient was, for example, taken out of a car that went over the roof. This all gives you an idea of what could have been damaged, and it's very important. So that's high energy trauma. High energy trauma is also trauma from gunshot wounds, because that's also high kinetic energy. So all these criminal activities, war injuries, all belong to high energy trauma. Part is also crush syndrome and blast syndrome that happen in specific situations. Now, I've mentioned here also a definition called polytrauma here in the Czech Republic, and I've searched a bit in the other countries' definition. It's more or less similar. It's trauma in patients whose injuries involve various body regions where at least where the combination or at least one of them can cause life-threatening conditions. So if you, for example, have a broken wrist and a broken ankle, that is not polytrauma. That means two different areas, but it's not a definition of polytrauma. But a pneumothorax and, for example, a brain injury would be considered a polytrauma. And these patients have a certain response to the injuries that is universal. And I am a surgeon, so I'm not really very good at molecules. That's why I chose surgery, because we surgeons find it hard to believe things that we can't see or touch. But it's good to keep in mind what happens in the body when the patient is exposed to this trauma, polytrauma even bigger, or basic elective surgery. So what happens? Certain organs that are affected and all end up in what is seen in the diagram at the bottom, systemic inflammatory response, or SIRS, a syndrome of inflammatory response. It doesn't have to be associated with a bacteria. If it's associated with a bacteria or some microbe, then it becomes a sepsis, and all this results in multi-organ dysfunction. Now, what happens? The first, what happens is it's a stress reaction, fight or flight. So the body, if I want to make it simple, shuts down the things it doesn't need. It doesn't need the gastrointestinal tract, so that is shut down completely. These patients are not digesting at that time, and they have this centralization of their circulation. That means the blood is sent to the areas that need it the most, which at that moment is the brain and is the heart, and are the organs that are vital for survival. Of course, who is very vulnerable, or which organ is very vulnerable, are the kidneys, and the kidneys are quite a good indicator of how serious the SIRS is, the systematic inflammatory response. So if the patient is urinating, then you know that this condition, or if he starts urinating, then that's a good indicator to know that he's becoming a bit better. Now, what is a real problem problem in this situation is a coagulation, because part of this trauma is associated with some sort of bleeding, and the body starts clotting. That's a normal reaction, and then again starts dissolving the clots, and this can become a vicious circle that, if it becomes completely uncontrolled, then this can be one of the major factors that causes the death of the patient. And then we have acidosis caused by an elevation of lactate. So it's all these things, this vicious circle, that this condition becomes worse and worse. And our main aim is to intervene and stop this vicious circle. So that's like the basic of the pathophysiology. I will mention a bit about the lethal trait a bit later. Now, I'm not really a big fan of various scoring systems, but on the other hand, they are necessary for doctors all over the world to be able to communicate together, because by saying he has a broken ankle or a broken wrist, or he has bleeding into his abdominal cavity, it can mean a lot of different things. It's a bit subjective. So they have developed some scoring systems. A very famous and international one is the injury severity score. And based on that, you can calculate the abbreviated injury scale. Now, here I have given you a print screen of the web page, and you can see that to be able and to learn how to define the abbreviated injury scale, there's even courses and special schooling and lectures to learn it. So it's not something that is very easy. It gets a bit complicated, and it's then good for comparing our results. But in practice, when I get a patient with abdominal or thoracic trauma, that is not the first thing I do. I don't calculate, at least not in my hospital, because we don't have a lot of polytrauma patients, and I'm working on the patient. But on the other hand, it's good to know that something like that exists. Now, trauma surgery or the polytrauma, the high velocity trauma has diminished very much with the development of various safety features. So just so that try to keep your attention focused and make the lecture a bit more interesting. Oh, I'm sorry, I have a note that the free meeting will end in 10 minutes. Shall I concern myself with that, or does it matter?
I will deal with it immediately, but
okay.
it shouldn't be there.
Okay, can you see it as well?
Yes, but you can continue, it's fine.
All right. So with the development of a seatbelt, the car injuries or the traffic injuries became less severe. And it's very interesting, because I also enjoy searching surgical history. I like reading books about old surgeons from previous centuries. The seatbelt was invented in the 19th century, and it was Volvo, one of the safest cars that started advertising that their car is very safe with the seatbelt. I'm sure most of you can't even imagine driving without a seatbelt nowadays. But on the other hand, the seatbelt injuries have become typical, but they are always the lesser bad when compared to what can happen if you don't have a seatbelt. So what's typical are sternal fractures, burns from the seatbelt, and sometimes damaged, ruptured small intestine because of the belt that is around the stomach. But they're good things. So wear your seatbelts, okay? Now, this here, I'm sorry about this slide. I put it for the Czech students. This was a video from an old Czech film, and it's not translated to English, but I will explain to you what's happening. The accident that happened was an accident in the field where a person was run over by a tractor, and this is his colleague going to the village doctor, knocking on the door and telling him, please come, there has been an accident. So this this is how it worked before. And I'm sure you're from different countries. And here in the Czech Republic, we have a lot of bad things. We have a very bad politics and very bad COVID management, but we have a very large network of hospitals. So here you can get to a hospital in an hour's time. So you don't have to go knock on the village doctor. But what you need when you obtain a medical history, and that's what happens in the film, he knocks on the doctor's door and says, someone's been run over by a tractor. That is exactly the information you need. What sort of vehicle it was, how fast it was, were there any safety features, how high, and I mentioned this at the beginning when I was talking about the medical history. And this is the guy who was stuck in the mud. Again, I'm sorry, the video is not running. And now, oh, it is running. So this is how he is examining a polytrauma patient, all right? The village doctor. It's a very famous Czech film. So this isn't exactly what you would be doing nowadays. This is not the way you should be examining a trauma patient. And then he sends him home and tells him not to drink any alcohol. Okay, so that's not what you'd be doing nowadays. And this is what it looks like now. So a trauma patient is indicated to be brought to a trauma center. This is what the trauma center in Motol looks like. You have monitors, you have oxygen, you have a vacuum to be able to have suction. And usually the trauma center is next to an X-ray or CT scanner. And if a trauma patient is brought into the hospital, the medical service gives them information. We are bringing a trauma patient, and everybody's on the spot waiting for them to arrive. If it's injury of the brain, they arrive even with the neurosurgeon or the neurologist who so they are there waiting for the patient. So this is a bit different than the village doctor from the film about 40 years ago. Now, your basics, the diagnostics and the therapy are done very quickly, much quicker than you're used to in your other specialties. The first basic thing is measure the vital signs. The same time, the nurse is already drawing blood, and she's drawing blood for a blood group, measuring ECG, and ideally you have a bedside ultrasound, which will tell you if there is a liquid in the thoracic or abdominal cavity. If the patient is stable, then you can take him to the CT scan, and a CT scan of head, thorax, abdomen lasts or takes about 5 minutes, even less. And it's best if the surgeon goes with the patient, stands next to the radiologist, and the radiologist tells him this here is damaged, and directly they move on either to the ICU or to the operating theater. So they're not wasting any time calling each other, what can you see, or waiting for the radiologist to write the report. This is of course an ideal state, and this is how it should be, but it isn't like this always. So now I will ask you, is the speed of the lecture fine, or do you have any feedback you'd like to give me? I can accommodate any of your requests.
Everything is perfect. We can carry on. Thank you so much.
Okay. So let's see if I can get on the next slide after the heartbeat finish. Okay.
I'm a first-year student, medical student, and I understand everything. So
okay, good. Good. Well, I hope I inspire you. And which country are you from?
I'm from Sweden, so from Karolinska Institutet.
And you are in Sweden right now?
Yes.
Okay, big respect. It was your government that chose the best strategy for COVID, even though at the beginning it didn't look like it, but you chose how not to ruin your economy. And now you have less deaths than our wonderful country that ruined economy and the lives of our children. So congratulations, Sweden.
Okay, I don't know if I can myself can take credit for that, but sure. Thank you very much.
Okay, so I'm not going to feed you with too many statistics because you won't remember them anyway. So I try to choose the ones that are relevant and at the same time make them easy for you. So when it comes to the thorax, and I will be speaking about the thorax, 70-30. So 30 of the injured that are brought with some trauma have thoracic trauma, but the thoracic trauma can be a concussion of the thorax or one broken rib. It doesn't have to be a serious injury, right? But that is considered a thoracic trauma. And if they are brought in with a thoracic trauma, they can have 70% of them can have another injury. Now, that is important for your clinical practice. It's quite a common mistake for young doctors to send a patient to an X-ray. They see a broken rib and they say, okay, one rib, you can go home. But remember what I told you at the beginning, that it's some sort of a kinetic energy. And usually with a broken rib or some sort of a thoracic trauma, I have to think that there can be also abdominal trauma, or there can be other trauma that the patient is not really aware of because he has pain in his thorax. He doesn't realize that his finger's broken or his elbow's painful or his ankle is. So that's why a patient, if there's time, and if there's not, then leave it till later, but should be examined completely because there are a lot of things that he doesn't at that point of time realize that are troubling him. Now, in the thorax, luckily for all of us, most of the injuries are closed. So we are happy because the open trauma can be very dramatic. This was a patient, not my patient. I sort of borrowed or stole this picture from another lecture, but it's interesting. This was a worker who fell on the roof, and I have to find out what the translation is, but it's the rod for thunder, for lightning. I don't know what it's called in English, the lightning rod. So he fell onto this rod and he was brought into the operating room. Obviously, the open or penetrating trauma is much more serious, and what the rescue service did is they didn't remove the rod. They just cut it and brought him in like this, which is very good because the foreign body causes a tamponade. We don't know what, at this point on the picture on the left, we don't know how serious his injuries are. So it's better to leave the foreign object in place, bring him like this, and then fix it on the operating room where you can directly treat any damaged artery or vein or deal with the injuries. And this patient actually survived this injury. So he is living a happy life. And now, so that's that's exciting, of course, for young doctors and surgeons. But if you want to become a surgeon, then that's not what you'll be doing when it comes to thoracic treatment. What you'll be doing is, in most of the patients, you'll be telling them that they should not be smoking. They should spend their time in a sitting position, because while sitting, they are using their auxiliary muscles to expectorate, to cough out. You're going to prescribe them analgesics and give them inhalations and recommend physiotherapy and wait for the body to deal with the problem itself. Now, sometimes we get patients which have more than one broken rib, and I think I'll mention it in the next slide. Let me see. No, sorry. The bracket says epidural. If they have 3 or more broken ribs, we call it a series fracture, and that's a patient who has a lot of pain. So automatically, when such a patient comes in, we offer, if the analgesics he gets per oral medication or IV medication is not sufficient, we offer them an epidural, because now, you know, I'm getting older, so I get a bit philosophical. Your main motto when you become doctors is pain management is one of the most important things you should be concerned about It's not ethical to leave your patients in pain. So we try, and my department tries to focus on this. Of course, things like nutrition and antibiotics and kind words are important as well. But it is completely unethical not to manage pain properly. And it is a known fact that patients with pain heal and their condition worsens much more than the patients who are managed properly. So if the analgesics they receive are not sufficient, we offer them an epidural. And for those who are younger, it's a catheter that is placed inside the spine. It's not into the spinal cord, but into the epidural area with a continuous continuous administration of morphine or opiates or medication that makes the lower dermatomes anesthetic or painless, and it helps the patients. And with the good pain management, they cough better, they expectorate, and they are less prone to have pneumonia. Now, here are a few pictures. I tried to mark the ribs for you with the arrow to show you where it is broken. If you don't see this on an X-ray or you miss it, it doesn't really matter, because the treatment with one broken rib or with no broken ribs or with 2 broken ribs would be the same. Okay, it's important, for example, for forensic reasons. If the patient is in a fight or is assaulted or needs some insurance, then yes, it should be, but it's not always very easy, even for experienced surgeons, to identify a broken rib. Now, here are some pictures that are a bit more clear. You can see up there. Can you see it? Is it visible? I try to put the arrow so you can.
Yes.
If you're not sure, you can do a CT scan, but it's not necessarily obligatory. You don't have to worry too much if the ends of the ribs don't meet, because there's quite a big layer of intercostal muscles, and the corset that holds the ribs together is quite strong. So even those fractures that are not in contact can be treated conservatively. Now, if you're not sure, this is something that's not obligatory. It's like we do it when we feel it's necessary, and we like these pictures because we can see the whole body and we know where everything is. So we like these 3D reconstructions, and here you can see how the ribs are dislocated, and usually before we decide, some broken ribs are indicated for surgery. I'll get to that in a little bit. So we ask for these 3D pictures, and based on them, we can decide whether to reconstruct or not. Now, here you can see 3 broken ribs. So 3 or more is a series fraction. Such a patient should be admitted to hospital. First of all, because of the pain management, even though they often don't want to, the pain lasts for 4 to 6 weeks. They don't stay for 6 weeks in hospital, but the first few days are critical. It usually gets worse the 2nd, 3rd day. So if you have a patient like this, please persuade him to stay in the hospital, at least till the next day. The next day, he'll be kissing your hands and thanking you, because they get into a lot of pain. And they should have a checkup X-ray, because part of the broken ribs can bleed, and they can be a cause of hemothorax that can develop a few days later. Now, here I have put some pictures of a sternal fracture. When I was studying, I read that the sternal fractures are quite rare. We've seen sternal fractures quite a few times every year. And again, they are associated with the seatbelt. So it's something that the old books say is not common, but we see them quite commonly. And what is obligatory with the sternal fractures is you should examine cardio enzymes, because it can be a heart concussion, and you should also examine and do an X-ray of the spine, because quite often associated with them are fractures of the thoracic spine. So the minute you have a patient with a sternal fracture, remember heart and spine. Okay. I'm not sure if it's obligatory in other countries, but here basically most of us use this approach. Now, this is a patient that came in and after a few days developed dyspnoa. And because we were aware she has a series fracture, you can see it on her right side. And because we are cautious and we know that a series fracture should be admitted, and now you know as well, so you'll remember that. After a few days before we wanted to send her home, we did the second picture where you can see that the water level has risen. Literally, it's not water, it's blood level has risen. So the intercostal arteries were damaged. They're not big arteries, not big vessels, so they don't cause hemorrhagic shock, but they can cause a few liters in the thorax, and it happens progressively. So a few days later, we did the checkup and we saw this, so we drained it, and we drained it for one main reason. The blood, the hematoma and the coaguli that are in the thorax organize themselves, as you have learned in the first years of medicine, and the ones that are in sixth year have already forgotten. I have also forgotten. And the hematoma changes into scary tissue, and the scary tissue will block the lung from expanding. So that's why we put the drain, we evacuate, because once it fibrotizes, becomes scary, then the lung will never expand. So you can damage your patient, mutilate him by not evacuating the hemothorax in time. No, and here are a few lovely pictures of our favorite pneumothorax, and this is actually quite an interesting diagnose, because you can basically diagnose just by examining your patient physically. Some of the older doctors are capable of listening; they have it in their ear. They listen, they can hear the liquid, and they know where the blood level is. But us younger ones, with all the CT scans and the X-rays and the benefits of modern medicine, we are losing a bit of the touch. But in a pneumothorax, when you listen to a thorax like this, where it's a pneumothorax on the left side, you will hear quiet. There will be nothing, and it's quite well distinguishable. And if you're not sure, you can do a consider it obligatory, and a simple X-ray like that will give you a clue of what's going on. Later in the lecture, because you have, or at least here in the Czech Republic, the students didn't have much practical education, so I try to put in some practical education. So I'll give you step-by-step procedure on how to start a chest tube. That should be general knowledge of every surgeon, but it's useful for the other doctors as well, because I've never had to give or start an acute chest tube for tension pneumothorax, but it's always good to know. And even the experienced surgeons are a bit scared, because sticking a tube, a pointed hard thing into someone's thorax, where you know that if you do give it too much energy, you might puncture the heart, is not pleasant, even for us who've done it many times before. Now, before I get to the chest tube, I will mention one more thing. I promised I will tell you most of the thoracic injuries are treated conservatively, but there is one condition that needs some intervention. And here up on the picture, you can see I have tried to explain, or the pictures explain physically how a flail chest works. Now, imagine the rib cage, the ribs. They are in a corset of muscles. Now, these are the ribs, and they are broken in two places. That means this bit here is wobbly, just fixed by the muscles that can also be damaged. Now, the patient who is inspiring, and you expect the thorax to expand, this little wobbly bit falls in because it is loose. And when he expires and you are expecting the thorax to push the air out, this wobbly bit is also pushed out because it's not attached to anything. This condition can, if it's a big area of the flail chest, and it is flail means it's like a flag, it's flowing in the wrong direction. This can be a big problem for their ventilation, and the patient can start choking, have a low saturation, and have breathing problems. So there are a few solutions to this, and one of the solution is, it's called a pneumatic splint. It has like this sort of complicated name in translating it from the Czech language, but it's nothing else than artificial ventilation. If you give the patient artificial ventilation, an endotracheal tube, then you are going to force the thorax to expand, and at the same time, after an inspiration, and become smaller when he expires by the pressure that is of the air that's sent into the trachea. And this is applied for 5 to 7 days. And during this time, there will become a healing process. It's not the bone. Yes? Okay, the bone won't heal in a week's time, but they will start having fibrous and scary tissue that will hold the chest or this flail part in the spot. Now, if this doesn't help, the damage is big, then we have the picture at the bottom where we can fix the chest with these splints that are operated into the patient. But this is done quite rarely. It's not very common. So I've tried to make or give you some sort of a conclusion about the thorax. That means a list of conditions that deserve inpatient treatment. So please notice that on my first spot, as I told you, pain management is very important. So as soon as the patient is not able to manage medication orally, or you cannot provide adequate pain management in his home, he should be in the hospital and he should get adequate pain management. If he has 3 or more rib fractures, because you saw that the hemothorax can appear after a few days. If he has sternal fracture, if he has pneumothorax or hemothorax, if you have a suspicion of other injuries, okay, and if there are life-threatening conditions, for example, like flail chest or a foreign body or something that you know that he needs artificial ventilation, or he needs some sort of an intervention. So these are conditions that I would recommend for you to hospitalize. I haven't mentioned one, I realized it now. If he cannot manage at home by himself. Here in the Czech Republic, we sometimes have to, because we don't have a really good network of social beds. So sometimes there are old people who can't take care of their shopping or their cooking, and they have nobody to take care of them. So we have to do these like social inpatient treatment. In other countries, they have a bit better organized the facilities. So very often the surgical department is filled with people who really don't have anywhere to go or can't manage for a few days on their own. So that can also be a reason before you send your patient home. And this doesn't really, it's not only trauma, it's everything. Make sure you know what he's going back home to, all right? It's even though we're surgeons and we don't, like we should, but we don't deal with the details too much. You should always ask if there's somebody who will cook for them or who will shop for them, or if they have, they live on the 2nd floor without an elevator and they have a broken leg, well, how will they get their shopping? So, if you want to be good doctors, think about all these factors together. Okay, and here's a list of the life-threatening conditions. So just a sort of revision. Now, if the thorax is bleeding, you can consider surgery, but most of the hemothoraxes stop conservatively. If you have a tension pneumothorax, it's obligatory to apply a chest tube even before you go to an X-ray. Now, a tension pneumothorax is something where upon inhalation, air goes into the thoracic cavity, and during exhalation, it doesn't go out because there's tissue that works like a one-way flap, and he is inspiring air through the thoracic cavity from the outside. What happens is the amount of air augments, and it can move the mediastinum with the vital organs to one side, and then cause impairment in the venal return and cardiovascular problems. So attention pneumothorax, the minute your patient has a low saturation, is blue, is in respiratory distress, you do not hear the long breathing, and you feel you won't have time to go for an X-ray, you can start with a chest tube directly. It's not a mistake. Now, flail chest we have discussed, and of course, part of the thoracic or respiratory tract trauma can be airway obstruction. So if your patient is, for example, found under rubble in a earthquake or in a blast, and for some reason he's not breathing, you don't know why, you can hear the lungs, but something's wrong, don't forget to look into the oral cavity and remove any foreign bodies. That's what you should start with, because sometimes it can be just a foreign body. That's a problem. Okay. So, and here's the chest tube. So now tell me, would you like a break, or do you want me to finish the thorax and then then we'll have a little 10-minute break?
I think we can continue. I think it's better like
okay,
this.
your attention is fine. All right. Okay, so this is like the practical part, because you didn't have much practical. Actually, I'm very honored that you want to listen to me, but to be quite honest, I'd much rather listen to you, so you could tell me where you are from and what you are studying, because that can be very interesting, whether the things are different in your country. So maybe when we discuss later, if you could tell me where you're from and if you do things differently, that's always very interesting for me. I like to hear that.
For sure, and we've already gotten some comments in the chat of
Okay,
people introducing themselves. So
they're not too negative.
no, not at all. They're all positive, and I'll read the chat for you later on.
All right, thank you. So how to start a chest tube. Now, the first year students are lucky because they remember their anatomy. We don't remember the names anymore, but we know that things are there, which is very important. And what's important here is you can see the two ribs, and there are intercostal vessels, a vein and an artery that are below the rib. There's also some collateral branches that are above the rib, but they're not that interesting. On the picture, they are the same size, but in reality, it's the ones that are below in the costal grove that are more important. Now, before I start my chest tube, I have to have prepared some sort of a collector. Now, this surgeon, Mr. Bilau, invented this drain where he had three different glasses, and one of them collected the blood from the thorax. The other was a water seal, the middle one, and the third one was to a suction source. Now, this was important because if you suck directly, you don't have any regulation and you can suck too much or too little. So that's why, and it's not sterile. So that's why it goes through a water seal to make sure that you don't suck too much. And based on the last glass on the left, which goes to a suction source, you can see a tube inside with the label atmosphere, and it is this one based on the height, whether it is high or low, that will give you the strength of the suction from the thorax. So this is basically very easy. We have these glass bottles upstairs on the ICU. Our nurses know how to fix it. It should be changed. The liquid inside should be changed every day so that it's sterile, because you are inside a cavity, and it's very difficult to clean, and there are glass liquids and they're very clumsy. So we now use this system that you can see on the other side that has all these three compartments in one. It can contain up to 2,000 milliliters of blood, and is used to regulate, and you can either put it on suction or you can put it without suction. You can remove the contents and to keep it for a few days. So, and the patient can take it as a bag and walk around. So it's quite useful. So we have this modern. Now, how is
Horáková?
it?
Sorry,
Yeah.
Can I interrupt you for 1 second? Because we got a very specific question regarding your previous slide.
Yes.
It's actually a doctor. He's saying he's from Lithuania and he has been 10 years in orthopedic surgery. He's asking, why not only one bottle with the water seal?
Why not only with the water? Well, the first thing is if you have one bottle with the water seal, then the contents will mix with the water seal. So we want to measure how much. That's why there's a collection chamber. That's the first thing. The water seal is so that the negative pressure isn't too big. And the third tube enables us to regulate. If we want it high, or low, we move it up or down. Okay, so that's the principle of Billow's drainage. But if I want to collect blood and measure, I suck from the thorax. It's a bit difficult if there's a water seal. Of course, I can subtract the amounts, but it's better not to mix the system and keep it separate. Okay. So did I answer the question?
I believe so. Yes.
Okay. So now this is how we apply the chest tube. It's always useful to ask the patient to put his arm up or behind the head if it's possible, because the ribs they move apart from each other, so that you have more space to choose the place you're applying the chest tube. Now, there's a lot of different places that you can put the chest tube. Either some schools recommend this upper area, the second or the third intercostal space. Some recommend the dorsal area. We're not very fond of either, because if it's dorsal, the patient lies on his back. If it's in this area, then it's first of all visible with an ugly hypertrophic scar. This area from the neck to the nipples is an area which doesn't heal very properly, and you damage the musculus pectoralis major, which is an auxiliary breathing muscle, so it's not necessary to damage it. Now, our favorite is the front axillary line, and we apply the chest tube in the third or fourth intercostal space. And even obese patients have a very well palpable edge of the musculus pectoralis major. So we palpate this edge, and behind it, so that we don't damage the muscle, we apply the chest tube. Of course, I'm not saying the other methods are wrong. In medicine, what is correct is what you do well. So we've had a discussion whether a central line should be subclavia, or whether it should be femoralis, or whether some do axillar, some do jugular. So the answer is whatever you know how to do, and you do it with little complications, that's fine. So I'm not, forcing you to accept this, but just giving you what we have a good experience with. So I suggest for beginners to lie the patient down and mark the spot. It is done in strictly sterile conditions. That means the patient should be draped as if in operating room, because you have a ill patient and you do not want to make the situation worse by introducing an infection. So wash your hands, wear sterile gloves. I teach my doctors to wear sterile clothes as well. You do an incision and you dilatate. Ideally, I like to use my finger, because some obese patients, it's difficult to realize where the ribs are. And when you apply the chest tube, the entering should be to try and preserve the intercostal arteries. So you will sort of brush the rib, but always brush the upper edge of the lower rib. Now we have some pictures here, so you can see that the spot is marked. Now I would caution you to apply a chest tube lower, because some patients have quite high diaphragm, and it can be underneath the diaphragm on both sides are parenchymatous organs. So if you apply a chest tube, be careful not to go too low, because you can damage the liver or the spleen. So after you've marked the spot and you've draped the patient properly, you apply some local anesthetics, you make an incision, and then with the dissector you dissect. you check your direction, and then you apply the chest tube. Now here they are applying it with a dissector. We have chest tubes which have like a hard needle inside, made of plastic. So we puncture the pleura. It's not a very pleasant feeling for us, because you have to develop a strength that is just right to puncture the pleura. At the same time, you don't have to, attack the other organs. So to be quite honest, I've done it many times, and I still approach this procedure with great respect, because of a lot of things that can go wrong. And that's to do with the thorax. So maybe the next is the abdomen. So maybe if you want to ask a few questions now.
Yes, we do have a few questions. Well, actually, one question regarding this. I think the rest we can keep for the end. We got another question regarding the placement. If it would be from the fifth to the sixth intercostal space.
Yes, the thing is, what happens is we always aim at the fourth intercostal space. And then after we finish applying the chest tube, we do an X-ray, and it usually ends up in the fifth or sixth. So I won't lie, okay? We try and aim a bit higher, and we always hope it will be the fourth, fifth maximum. Sometimes it turns out to be the sixth, okay? So look at the first X-ray, check where the diaphragm is. Look at them in men, and you can try and guess in women. The level of the nipple is usually safe, all right? And sometimes it happens that it is a bit lower, right? But look at the X-ray. Some patients have a cupula like this. So in such a patient, be more to the top, okay?
Perfect. Thank you. Thank you so much. I think we can continue for now.
Okay. Well, would you mind if we had a small break, maybe for 10 minutes? And
sure.
Because this is like half of the lecture, so if you wouldn't mind giving me some drinking time.
Of course.
It's 17:53, so 10 minutes, 18.
For sure.
Is that okay?
For sure, yeah.
Okay.
So in the meanwhile, maybe I can let you guys know that I will put a link in the chat for the people that would like to get a certificate of attendance, as well as we would like to encourage you to leave some feedback for our lecture and, well, your experience with us for now. So in the meanwhile, you can do that. I will post the link right now, so you can do that. Here you go. To whoever fills in the feedback form, you will receive the certificate of attendance for this talk. Thank you very much. Dr. Marta, are you back? We can hear you.
Just a second. I found a video for you.
Perfect.
So I use the break to find a video, and I will resume the lecture.
Perfect. Thank you. Just want to make sure that we could hear you. Thank you.
I'm just getting ready. So shall we give them 1 more minute?
Sure, sure. Take your time. It's fine.
Okay, so I'm back. I used the minutes to find a video I had. This is after we have applied a chest tube to a trauma patient with a thoracic injury. And it looks a bit dramatic because sometimes when you apply the chest tube, there's a big amount of blood that is evacuated from the thorax. Now, it can look dramatic because we all know how much blood we have. And we get a bit scared if there's too much in the drain. But first tip that you should remember is if the blood is not clotting and is dark, it's usually old blood that isn't part of the system anymore. It's been there for a few days, so it will not cause any hemodynamic changes. So they have applied the chest tube, they have joined it with the system, and this is what it looks like, okay? So this can be a bit dramatic when you can see the large amount of blood. And as the patient is breathing, the system fills very quickly. But this is old blood that is not clotting and that is just evacuated. Okay, it is not the blood they are using from their system. You can see that in a few minutes there is about 600 milliliters of blood. So this is what was in the cavity, and my record is about 2.5 liters. I got a bit nervous after 2 liters, but it stopped itself after 2.5. So look at the way the blood is. I'll put it one more time. Okay, can you see the video? Yeah.
Yes.
Okay, so yeah, as a young doctor, this can scare you a little bit. Okay. I asked my colleagues to make this video for you. Okay, now the young doctor in Czech is saying we are going to stop it, so that isn't too much. He's a bit nervous, but his concern is irrelevant because this is blood that has been in the thorax for many days now, and it does not affect the hemodynamics. If you are evacuating ascites or if you're evacuating the urinary bladder, then yes, there I would be a bit more careful and do it in phases, but this is blood from the thorax where it shouldn't be a problem. Okay, so now I will try and put back the lecture. So just give me a second. I'm not as quick as you are. Share screen. Okay, so can you see the lecture back?
Yes, it's perfect.
Okay, great. So now I will move on to the abdomen. Now, this picture here is a very old picture. Again, it's not taken in our department. And this is a picture when we didn't have readily available ultrasound or CT scans. And the doctors had a suspicion that there was a liquid in the abdominal cavity. They were able to percuss it. And they did these diagnostic punctures, which showed them that the liquid is blood, and this was an indicator that there is some bleeding in the abdominal cavity. Of course, doing this without the ultrasound or without any sort of radiology is a bit riskful, because if you're not experienced, you can damage the intra-abdominal organs or the intestines. So I put this here as like a retro picture. I've never actually had to do this or never was present. Now, abdominal trauma can range from a variety of clinical symptoms, starting from being completely asymptomatic, and the most dramatic is hemorrhagic shock. So you can expect a wide range of presentations. Patient can have hematoma of the abdominal wall. They usually have abdominal pain because the damaged organ and the blood in the abdominal cavity is very painful. The peritoneum is very sensitive, so any stimulation of the peritoneum causes quite a lot of pain. So the patient has peritoneal signs, and they can also have a visibly expanding abdomen. I have seen this a few times. Last was about a year ago, when by accident they brought a patient who was struck by a car, and he had a lacerated iliac vein, and it was bleeding into the retroperitoneum, not the abdominal cavity, but the retroperitoneum. And he was in hemorrhagic shock, and we got him to the operating room in about 30 minutes. He went through a CT scan, and we saw how the right lower quadrant was expanding because the hematoma was pushing. So this was visible. Unfortunately, I was in action, so I didn't think of taking a picture, which would have been a very illustrative photograph, but I was focusing on the procedure, and we operated on him. It was a bit difficult to approach the iliac vein from the retroperitoneum, and it was lacerated, and the veins have a much more fragile wall as opposed to arteries. So we tried to suture it, but it was not possible. So we ligated it. He had edema and thrombosis of the lower extremity, but later on the flow was through collateral veins, and this patient survived and went home on his own feet. He walked back home. He was actually a psychiatric patient who probably jumped in front of the car on purpose. So that's what we found out later. So part of the first screening, again, is the lab work. Please remember that part of your basic lab work should also be a blood group, because you can expect that you are going to have some blood losses. You should inform your lab, or the nurse should inform the lab that this is a trauma protocol, because they start preparing a lot of blood transfusions, and often 1-2 is not enough. If it's a serious trauma, you can expect much more, and we give blood and we give plasma. Now, what's quickest in the emergency room is focused abdominal sonography for trauma. This is basically, instead of this diagnostic puncture of the abdominal cavity, it will very quickly tell you, if you have a hemorrhagic shock, which cavity has liquid, or which cavity has blood in it. So you are a bit more focused on the area in question. And if the patient is stable or stabilized, you can go for a CT scan, and I mentioned that at the beginning, so I won't repeat myself. Now, this here is a simple procedure where simple algorithm where you decide whether the patient is unstable, and you can see that he has liquid in his cavities. So you go directly to the OR. If it's negative or he's stable, you have time to do a CT scan and then reevaluate. So this is like the basic algorithm. So you don't waste too much time, waiting for a CT scan if you have an unstable patient. This is a moment where treatment and diagnostic happen at the same time. Now, this looks very, very complicated, and this is a sort of classification of the trauma of the liver and the spleen. I personally, maybe since you mentioned there's some doctors and trauma surgeons listening, maybe they won't agree, but I don't find this very useful for clinical practice. First of all, it's sometimes not very easy to identify by CT whether it's 1 or 3 centimeters in depth. Sometimes the ultrasound doesn't show anything anything, and then the CT scan shows that there's a laceration. What and I'm sure most experienced doctors will agree with me, what I consider most important is the patient as a whole. I don't like to solely depend on the CT scans, and that's something that a lot of the younger doctors do because they don't have experience. It's obvious. They look at the CT scan, say, oh, this is okay, and that's it. I mean, look at the patient as a whole, and if he's not getting any better, then you consider that there can be mistakes, and there can be human mistakes, even, for example, with the lab work. Just recently, we had a very low level of hemoglobin in a patient where we had absolutely no explanation why he should suddenly have hemoglobin of around 70. We were wondering why, so we asked the nurse to redraw the blood again, and in an hour he had 120. So we were wondering why, and we found out that the nurse who drew the first blood was a young nurse who drew it from the same line as he was getting an infusion. So it was blood that was dilated. So please, whenever you get a weird result in medicine, think as a whole, why is it so, and consider that there can be a human error. Now, this here is what it looks like in real life, the CT scan. I grew up in a smaller hospital where we were dependent only on ultrasound, but if there's a suspicion in ultrasound, we do the CT scan as well, because it is a bit more precise, or much more precise. Of course, the CT scan is a lot of radiation, so we try and think how many CT scans a young patient, this was a child, a teenager, should have. So we, for example, start with an entrance CT scan, and then we monitor the condition with an ultrasound, and only perform a CT if there's some sort of discrepancy. Here again, you can see a trauma to the spleen. These are very common traumas. For example, it can happen in old people when they slip in the bathroom and they hit their hypochondrial region or their upper quadrants on the edge of the a bathtub, or of course this was a boy on a skateboard, or youngsters, various sports, so it's not quite uncommon. And this is a sort of patient that comes into our hospital maybe with a broken rib, looking completely innocent, and he's not directed to a trauma center because there is no history or and he fell off a bike. That's not a patient who has to go to a trauma center. So even doctors in smaller district hospitals like my own should be aware of these problems, and should be aware that a patient that looks innocent can have some sort of a serious abdominal trauma. And here again, you can see that the laceration isn't complete. It doesn't go to the hilus, but it can be quite close. And another picture. See, this picture, I try to choose the best scans for you, but this is also not very clear how large the laceration is and what it looks like. So please depend on the patient as a whole, and not only on the radiology. Now, I tried to make this slide easy for you to remember. Hemorrhagic shock, well, you all know the definition, or those who have already had clinical medicine, that the shock is a state where the tissues are not getting enough oxygen, and the metabolism isn't able to proceed as it should. Now, we surgeons usually meet with hemorrhagic shock or septic shock. Sometimes we see anaphylactic shock. I'm not going to discuss them because they don't belong into my specialty, but hemorrhagic and septic shock, they do. Now, please realize that the amount of blood that you lose isn't infinite, and I always tell my students that 1 liter of blood is like 2 beers, and that can sort of be quite a serious amount of liquid. And if it is lost quickly, if it's not progressive bleeding due to a tumor or due to another cause, if it's lost quickly, it can affect the hemodynamics of the organism. And if the patient loses 4 beers, then that's 2 liters. That can be nearly half of the blood that we have, and that can also cause some serious hemodynamic changes. Now, how do you find out, or how do you realize that the patient is hemorrhagic shock? Well, at the beginning, you know that I told you that part of the screening, the first contact is to measure the vital function. So if the patient has tachycardia and hypotension, then it should hit you that something's wrong. They will have tachypnoa. They might have a lower saturation because logically there's no transport of oxygen to the tissues they need. They might have a slow capillary return, and they have signs of centralization. You will see that the peripheries are cold, that they are, as I mentioned at the beginning, they are perfusing the organs that need it the most. And when you measure their diuresis, you will see that they are not urinating, okay, because they don't have enough liquids. What is also typical is a change in consciousness. Some of them can be aggressive, right? You think they are drunk, they had a car accident, or they can be agitated, or they can be in a coma. They are not responding. This is all caused by the hemorrhagic shock. And then also postural hypotension. That means if they get up, that they suddenly have a reduction of systolic, it should be BP, blood pressure. Sorry, there's a typo. Now, when the patient is in the ICU, and if you have a continuous measuring of arterial tension, you can do a simple experiment. I call it, or it's called the leg rising test. So now imagine you have an arterial catheter and you are measuring the arterial pressure or the blood pressure continuously. You can raise the legs and watch the monitor, and if the blood rises, then you know he's hypovolemic, because by raising the legs you help the blood into the central system, and that will show you that he doesn't have enough liquids. A very simple, some of really cool things in medicine are based on very, very simple principles. Now, what you should do. I also mentioned at the beginning, it's simultaneous diagnostic and treatment at the same time. So such a patient who is in hemorrhagic shock should be monitored in the ICU. As a young doctor, you can ensure is 2 peripheral lines. Sometimes 2 peripheral lines are better than a central line because they are wide enough to give him liquids. Central line is good, but if you don't know how to do it, or leave it till a little bit later, okay? But always when the patient comes in, the first thing I ask is the nurse if she has drawn blood, if she has drawn blood for blood group, and how many peripheral lines, and the nurses are automatically trained to start another peripheral line because one can accidentally be displaced and so on. Urinary catheter, arterial catheter, these are things you would do a little bit later in a few minutes. Such a patient should have continuous monitoring on the ICU, monitor of oxygen, consciousness, urinary output. Now, such a patient, in most cases, these parenchymatous trauma, the ones that you saw, all these patients on the CT scan with the spleen, they were treated conservatively. Before, the tendency to operate on such patients was bigger, but now we are more conservative. We treat them with IV fluids, plasma, tranexamic acid. And if that doesn't work, then and the patient's not getting better, then of course we have to operate. So that's why he's on the ICU. And this is a picture of an old ICU, how it looked like, the monitors. It's not a space station. It's really a nurse sitting at the ICU at the monitoring the patients. Now, I will start.
Can I just ask a quick question? Because you were mentioning that sometimes 2 IV lines is better than a central one.
No, I didn't say that. I said as first aid. A central line's cool. Okay, that's good. But if you're now, the thing is, you're a young doctor at the emergency department, and you might not have enough experience, and trying to apply a central line, if you're not experienced, and if the system is collapsed, will waste your time. You need to fluids. So start fluids with a peripheral line. As soon as you have nothing to do, then go ahead, start your central line. Central line's good, but don't waste your time. Don't focus that this is the first thing you have to do, if you know what I mean.
Yeah, okay. And in the case that I do have two IV lines, because we're talking before about that mistake with the nurse that took the blood and it was diluted with the saline. How do I prevent that mistake from happening? Because after all, like, I'll want to control the labs the right time.
Usually what happens is the nurse draws blood and starts an IV line from the puncture she drew blood in. Okay, so you've already drawn blood upon admittance, and you can draw blood from anywhere else, but just don't draw it from the same place where she is putting the IV fluid. All right, you can draw blood from the inguinal region if necessary, but the first drawing of the blood should be done, and then you continue directly with an IV line. The nurses know how to do that.
And Dr. Horáková, we have one more question regarding what you had just mentioned. It is, how often do you use tranexamic acid in everyday practice?
Well, the thing is, we are surgeons, so we use it, well, let's say maybe, I don't know, once every 2 weeks. So we have a patient, just because we don't only have trauma patients, we have patients with other types of bleeding, post-operative or bleeding into the gastrointestinal tract. But tranexamic acid is not an alternative for bad quality hemostasis, okay? So we try and focus on doing, if for example, the patient has bleeding from the anal canal, which can happen. A lot of these patients have warfarin, or they have drugs, anticoagulation drugs, and they have bleeding, for example, from an area which is approachable to us, then we prefer to do local hemostasis. And I have met with doctors who give tranexamic acid, but they have bleeding from somewhere where it can be stopped. So yes, we use it, we like it, but we consider the mechanical, if it's possible to stop the hemostasis. And I was on a Congress of Sepsis 2 years ago, when we still were able to travel in Ostrava, one of the best congresses I've been to, because it's not only sepsis, it's a whole range of intensive care. And they were discussing the pros and cons. And again, I'm not a hematologist, so please don't ask me about that. But one of the doctors mentioned a case that somebody's giving tranexamic acid, but he has bleeding that he hasn't stopped, and he can see it and he knows it's there, but he hasn't done anything about it because he's given the drug and he thinks that's it. Okay, so it was, no, I'm not trying to degrade anyone. We all make mistakes. It's good to talk about them. So tranexamic acid, yes, but you have to solve the cause. All right. So I don't know if I answered your question, but I just want to stress this point, that sometimes we are so focused on one thing that we miss the other. That's, again, look at the patient as a whole.
The question was by Dr. Janovic. He's from Lithuania, and he mentions in the chat that in his hospital, they use it 20 minutes prior to big surgeries, as like a response to your answer.
Okay. Yes, some of our orthopedics doctors use it as well automatically. We don't. Okay, but to be quite honest, I haven't actually thought of discussing this. It's not really common because I'm a soft tissue surgeon. So for example, before a cholecystectomy, I probably wouldn't consider it. But I know that the orthopedic surgeries are a bit different. There are bigger blood losses, and some of our orthopedic doctors use it. Right, but it's not part of our preventive or normal routine. But thank you for the question. I might look into that a bit more, because I have heard this opinion before. Maybe it could be useful. Okay, well, anyway, so I'm going to move on to the lethal triad of death and damage control surgery. I told you at the beginning that the whole trauma starts this sort of vicious circle, and 3 things that we try and control from the beginning. Some are actually quite easy to control. Such a patient will be hypothermic. So what you should think of, apart from the IV lines and from the blood group and so on, is to start considering their temperature comfort. So do everything you can to keep them warm. Consider the coagulopathy, and a lot of the trauma centers have ROTEM, which analyzes the coagulation, and based on that, they then decide what sort of coagulopathy has occurred, and they give the adequate treatment. I'm not a hematologist, and we don't use this, so I can't answer, or I'm not, like very experienced with this. And this would be in the, I would say, the specialty of the anesthesiologist, taking care of the complete patient. And the third thing that bothers them is acidosis. So you have to consider that these three things are the lethal triad of death and can worsen the situation. Now, damage control surgery is actually quite interesting. It's a philosophy that can also be applied to the septic shock. And the whole principle is, the whole idea was to, because the surgical trauma also causes trauma. So the whole idea of damage control was to join the surgical, that means the procedure, and the accident or the trauma for the patient into one whole, and make it as finish the whole trauma, the surgery, as soon as possible. That means before, when we weren't aware of the damage control surgery principles, we tried to reconstruct as much as possible. We had a patient who, for example, had a damaged liver, had a ruptured intestine, had trauma of the extremities. So we now know that part of damage control surgery is to try and finish everything in 90 minutes. And there's two basic principles. The first is just performing life-preserving procedures. And these are two: stop the bleeding as soon as possible, and the prevention of contamination. For example, if they have a ruptured intestine, they are at risk because the intraluminal or the environment of the gastrointestinal tract, which is not sterile, has opened into the sterile peritoneal cavity. So we try and prevent further contamination, because we would worsen the situation by not only the trauma and hemorrhagic shock, but as septic shock as well. So what we try to do is we do as little as possible, but to prevent contamination. So, for example, to be concrete, we resect part of the intestine that is damaged by staples, and that's it. And we leave the reconstruction until a little bit later, when the condition of the patient has become better. The same goes for hemostasis. If I can make a vessel ligature or resect an organ very quickly, go ahead. But if I'm not an experienced surgeon, it's at night, I don't know how to do it, packing is fine. Packing, there's a picture later, means that I cover the bleeding organ or the bleeding area with a large amount of surgical drapes, and leave it for a second look after 48 hours when the volume has been corrected, coagulation has been corrected, thermia has been corrected. And then in the next phase, I reoperate, sorry, that should be number 3, and perform the definite treatment 24 to 72 hours later. Okay, now, this was a picture that I used for my doctors. This is a model for my students, model of the abdomen, where you can enter the abdomen using various incisions. Now, if you have a patient with abdominal trauma, then I would suggest and recommend you use the midline incision, unless you are 100% sure you are just going for the spleen or for an isolated organ. But we can sometimes be very much surprised at what we can find in the abdomen. The midline incision will enable you to approach all of the quadrants in the abdominal cavity. So I recommend, you might feel bad that you are making a huge incision and damaging the patient's lovely virgin abdomen, but you are trying to save their life. So cosmetics at this point of time are second hand. And this is a diagram of the packing, and this is what I did to the patient with the lacerated iliac artery. We ligated it, but there was a small bleeding from the iliopsoas muscle and from other areas of the kidney, but they weren't serious. On the other hand, they weren't such that I would leave them there without any treatment. We use various glues and various powders and various chemical substances that can stop the bleeding. But if you are stuck, you don't know how to do how to resect a liver, which a lot of surgeons don't know because it's quite specialized. You pack the area with the drapes and you leave it for a second look where an experienced surgeon will come and help you. Now, what happens is when you open an abdomen, these pictures are lovely because you can see clearly the edges of the organs. When you open an abdomen where there is hemorrhagic, where there's bleeding, you usually get a huge amount of blood and blood clots, and it's not as clear what it is from. So the first thing that we do is we drape all the 4 quadrants to stop the bleeding, and then slowly we check each quadrant one after the other to find the damage that has been done. And here is an example of how they did a bowel resection. The damaged bowel was resected, it was stapled, and that's it. Of course, making an anastomosis doesn't take too much time. An experienced surgeon can have it done in 5 minutes, but there can be a lot more damage and there's no time. So this is an option, all right? And it doesn't have to always be the small intestine so clearly available or so easily accessible. It can be, for example, a knife wound with an area of the large intestine, the lienal flexure, which is not very easy to access. So, you know, make a stoma or close it, leave it, and consider second look a bit later. Now,
Dr. Horáková, I'm
yes.
sorry, if I can interrupt you for 1 second. I missed one question from our chat. It says, what about COVID? Do you go full level 5 into the OR?
What do you mean, a COVID full level 5? I didn't understand the question.
The question says, what about COVID? Do you go full level 5 into the OR? I'm not really sure. Maybe the person that asked the question could type a follow-up question.
Excuse me for 1 minute because my computer is signaling that my battery is
Sure.
So I will just plug in and I'll be back.
Yeah.
Just give me a little minute. Okay, I'm back. Thank you. I think maybe our colleague thought if the patient has COVID, if we operate, or I mean, I can't really imagine we're waiting for the results. Luckily,
it means he meant in personal protection, full suit.
Okay, very good question. Well, the thing is, we haven't luckily had this sort of trauma. The last one was last year, actually. I think it was before COVID. It wasn't in April, it was at the beginning. So we didn't concern ourselves too much with COVID when we did this patient with a laceration of the iliac vein. Okay, to be quite honest, the situation here is such that the rules are changing every day. So just like a small brain break for all of you. We started off by testing only patients who had symptoms. Then half of the hospital started testing all the patients. Then some doctors said we won't treat anybody without tests, even though the rules were a bit different. So like with everything in the Czech Republic, people were sort of making their own rules. So now we regularly test everybody who comes as an inpatient because we don't want it to impair their further treatment. If the patient is suspicious, we have this questionnaire, they have points, and if they get 1 or more points, then yes, we wear full COVID protection. we have an operating room that is reserved for COVID. Now we have a lot of people who test positive but don't have any symptoms, and we have a lot of elective surgery patients who test positive for 3 months continuous and they don't have any symptoms. So we have maybe 50% of those. So it makes things a bit complicated. We treat some cases individually, but the question's actually quite good, because what's most important is, yes, you have to protect yourself, full protection, but COVID or not COVID, I always tell my doctors, the patient mustn't be affected by, mustn't not receive treatment just because we don't have the COVID result. So if there's a suspicion, we wear full protection, and we've operated with full protection. It takes a few minutes to get dressed, like you all probably know, but I don't think it's correct to say there's no PCR test. We don't know yet, so we'll wait for the treatment, right? If, sometimes it does happen when somebody says, well, I don't know if he's PCR, so I'm closing my door and I can't treat you. That's completely unethical. So yes, we've operated in full 5, but not a trauma patient, luckily. Okay, so anyway,
Thank
this
you.
is the last bit of my lecture about mass disaster. Now, to be quite honest, I won't lie, I haven't been to a war zone. I haven't been a part of a mass disaster. We have had a activation of trauma plan in our hospital a few times here. So I will, but it's not at such a big scale. This was when I prepared the lecture. This was the big explosion in Beirut. I had a little bit of a political problem because I was trying to persuade the management of the hospital to practice the trauma plan, to practice the mass disaster a few years back, and the approach or the response was, this will never happen in our country. So a bomb or an attack or something. Now after the pandemic COVID situation, where 2 years ago we thought this can never happen, we have, or the management has changed their views a little bit. I'm sure the people in Beirut also didn't think that this could happen in their country. Actually, the reason I chose Beirut is because my father is from Beirut and I have a lot of relatives there. So it's like also a personal thing for me. And so that's why. But I'll get back to the medicine now. So excuse my personal. Now, this here is a mass disaster that's doesn't look as dramatic as the Beirut picture. This was something that happened in Pisek, in my city, the one where I work, in '56. It was a bus that fell off the bridge, and it doesn't look as dramatic, but a small hospital like this, when received 70 wounded, 15 heavy injuries, can be occupied. It's a very intensive amount of patients, and even big hospitals like the Motul hospitals, the amount of means are not indefinite. Now, what's very interesting is it's never a question of beds. Never a question of mattresses. And those of you who have had or worked or had the possibility to work in a war zone or have something to do with mass disasters know that you can put the patients anywhere. What is limit is the personnel. And that's something that the pandemic proved as well. We have a lot of beds. We have a lot of mattresses. When a mass disaster occurs, you can have people on the floor. It doesn't matter, but you need personnel to take care of them. So that's what is usually the limit. And then after a time when the mass disaster or dealing with the mass disaster lasts for a few hours, then you can also reach the stage where you have not enough supplies. But the first thing that's a limit is always the personnel. So what happened here was a doctor riding on this bus managed to get out. It was in the year '56. She ran to the hospital, which is about 10 to 15 minutes from this bridge. She alarmed the doctors there. They all, the driver went and picked everybody from their home. They all arrived to the hospital, and it took them 24 hours to treat these patients. So I imagine a small hospital like ours, where there's 840 employees, and in this year there was much less, had to deal with the 70 wounded. That's actually quite a good job, you know, for them, for a small hospital like this. But mass disaster doesn't have to be a bomb blast. It doesn't have to be a car accident. It can be caused by human beings. Josef Flada is a very famous Czech artist. He's an illustrator of a lot of children's stories. And this is one of my father's favorite pictures. It's called The Fight in a Pub. So you can have a fight in a pub where you have 5 patients or 5 people who got blows to their abdomen and thorax. And this would also occupy my hospital for a few hours. So it doesn't have to be big time. It can be also something like this. Now, this was a mass disaster. We call it in Czech hromadný neštěstí in Písek in 2016. And what's also a bit like interesting is I started working in this hospital on the 1st of July 2016. And when a mass disaster happens, there's always one person who is responsible for triage. Triage means choosing who is going to be treated and who is not going to be treated. And we study this within our specialty. It's based on war medicine, and like with the pandemic, it's similar. It just is in much shorter time span. It doesn't last for 2 years. We have to choose and say, okay, we don't have enough personnel. We will invest into this patient, or we will invest into that patient. And what was interesting is the person who's responsible, it depends. Each hospital has it differently. In our hospital, it was the surgical chief, which means me. And I was employed for 14 days. And 2 days before this, I went to the technical department for extra schooling. I got some extra, like everybody's trained, I got some extra training, and I left and I was saying, okay, so now I'm ready if there's a bus accident. And the person tutoring me said, well, that will never happen here. And 2 days later, I received a phone call from our contact saying that there has been a bus accident transporting 40 school children for a trip, and that they have had an accident on the highway around Písek, and they're bringing them to the hospital. Now, this is what it looks like. Okay, now this is a bus. So we found this on the internet. This is actually what the pictures looked like. 40 school children. So you have to consider abdominal trauma, broken ribs, head trauma, skin lacerations, and 40 children. That means 40 human beings that have had some sort of an injury. At that point of time, it was during the working hours. I had 10 doctors here, approximately, including myself, plus a few of them in the operating room. So let's say maybe 8 or 7 available doctors and 40 patients, and you don't know who is the one, which one is bleeding into their abdomen. So it doesn't have to be a bomb blast for the situation to be a bit dramatic. Now, what we did is we stopped all elective treatment. We, the patients that were in the outpatient coming for the redressing, we diverted them. Luckily, and this system is quite good, the ambulance didn't bring all the children here. The first report was 40 children, so we stopped all our elective work. And then the number was less, of course, and they distributed them to different towns around. So 4 children went to Tábor, 4 went to Strakonice, 2 went to Prachatice, and 14 arrived in Písek. But still, 14 children, 10 doctors, not knowing who's the one bleeding can be a bit of a problem. So luckily they were just minor injury. 3 of them were admitted as inpatient. 1 child had a suspicion of a spleen laceration. Most of them were in shock. And what was very complicated is it's just a logistic thing, but it's thing that, you know, I am also responsible for. They were school children and they had no IDs, or they had the ideas with the teacher. So the ambulance brought them in and they were in shock. Of course, they were at an age to know their full name, but they had no idea of their insurance number. So they came in saying, I'm Peter, I'm Anička, I'm Verunka, I'm Veronica, in shock. And for us to be able to get them into the system, make the x-rays, make the lab work, we had to very quickly improvise, because we didn't have a system then, make some identification. So each of the child got a number, they got a tag. Nurses wrote the tag, they wrote the number on their hands because they were small children in case the tag got lost. Of course, this now has become better. We now have formal tags. The ambulance service forgot to give them tags. So we had 14 kids. We didn't know who is what, whose x-ray is what. So the situation can get a bit dramatically. Luckily, no serious injury. The child that was observed for a suspicion of spleen laceration, it wasn't confirmed. Now, this is a sad slide, mass casualty incident triage. This is something that you wouldn't use in civil medicine. It's actually quite easy to remember. So if the patient is walking, you consider him green. He doesn't need immediate attention. If he's not breathing, then you clear the airway, because that can be a very simple and quick maneuver. If he's still not breathing, you consider him black. That means no further treatment. This is not what you do in civil. This is what you do when you have too much patients and you don't have enough resources. And it's this triage that is done by one of the most experienced surgeons, one person who's deciding to do this. If the patient is breathing, then you decide whether he's red or yellow, whether he needs to be treated first, and whether he can wait a few hours. Now, it is the responsibility of the leader of the trauma plan to decide how he's going to position his doctors, how he's going to position his nurses, and what color he gives. And these colors are not definite. That means if somebody is identified as a green and he's sitting in the waiting room waiting for his turn, there should be somebody who checks on him in a few hours or in a few minutes, after half an hour, 1 hour, because he can turn into red as well. He can have a spleen laceration, but it doesn't have to be obvious. He's walking with his spleen laceration. In a few hours, his situation gets worse. So it doesn't mean that, you know, he's walking and that's it, I ignore him. That's why when this is dealt with, it requires a lot of personnel. And I think if something like this again happened, we definitely need the help of the gynecologist. We need the help of the internal medicine nurses and the doctors, for example, to care for our elective patients while we're dealing with this. And this is the card that they come in with. And the accident with the children, the ambulance service forgot it. So they didn't bring it with them. So there was no number. There's at the top, you can see there's a number. And they do this color triage in terrain. And then when they arrive to the hospital, we can change the color because it's been a few minutes and maybe their condition has developed. So this is what they use to decide who they are going to bring to the hospital first and who they are going to bring second. And now we're nearing to the end. And 2 years ago, before COVID started, I forced our management to accept, because on the ambulance service, there's a colleague of mine who also has this as a personal hobby. And we decided, we organized a big training. These are pictures from training in our hospital. And we chose an old building where we simulated the patients in the golden blankets are students of a medical school or nursing school that are, they were masked with blood, and they had cards with their symptoms. They arrived to the hospital and I gave them the types of injuries we'd like. I didn't tell my own doctors. I was the only one who knew the types of injuries. and we practiced, and we found out that we have a lot of things that we need to improve. For example, we don't have a central pipeline for lab work. So we had to allocate one person who's going to be running to and from the lab, taking the test tubes. We found out that if we don't have their security number or their insurance number, we need to develop a system of how to identify the people. We found out something really silly, that after 2 hours of work, we were all extremely thirsty because we were running around and simulating. So we need somebody to take care of our well-being and bring us something to drink. We found out that there were no garbage bins in the corridors. So after treating somebody, we took off our gloves and threw them on the floor. So we need somebody from the technical department to take care of these things. We found out that the elevator is locked, that the doors don't open because the keys are available only to some personnel. The anesthesiologist found out that they have only one ventilation machine on the ground floor, so they needed to establish another one. So thanks to the practice, we found out that there's a lot of things that we can improve. And we wanted to do it last year, but COVID came. So now I have to wait because COVID's not my diagnosis. I hope next year that we can do this training again and we can employ the whole hospital. And I'm sorry, there's a mention of the Department of Surgery, second medical faculty. It's a lecture I did in autumn. I don't work there anymore. So ignore that, but the email and the phone are fine, so they're valid. So that's it from me. And now it's time for you.
Thank you very much, Dr. Horáková, for your talk. It was very, very interesting. For the rest of the people, please feel free to send any of your questions or comments in the chat box. We have 2 questions that were made in the beginning of the lecture. So I will go ahead and read through those first, if that's okay with you.
Yeah, go ahead. I opened the chat, so.
Oh, okay, but they're way back up. So I'll just go through those ones that are old ones.
Tell me the questions, go ahead.
So Panagiotis asked, through which medical specialties can someone become an emergency specialist and become involved with polytrauma patients?
Okay, there's 2 things. There's actually 2 different things. First of all, if you want to operate on these trauma patients, then you need to go through surgery, trauma surgery, and it takes, and I know I don't want to scare you, but to be able to confidently operate on patients like this, 8 to 10 years of practice. A surgeon doesn't become a surgeon after 1 year, and it's not, I don't want to show off or anything, but it's because it's a skill. In Czech we say řemeslo. It means a skill. It's like workmanship. You want to become you work with wood, or you knit, or you sew clothes. It's work with your hands, so you need a lot of manual experience. Theory is good, you can learn theory in a short time, but you need a lot of manual experience. So to become a surgeon and to operate on these patients, it's good to start with surgery, appendicitis, appendectomy, cholecystectomy, bowel resection, and then when you enter an abdomen full of blood and coaguli, you can orient yourself. That's one bit. And the other part are the anesthesiologists and the emergency medical doctors. And these are the ones who understand the coagulation, the artificial ventilation, and it's always good if these 2 work together. It's necessary, because I don't know how to intubate, or I can intubate if necessary, but I don't know how to fix a machine for ventilation. Or I can do the basics, but not good enough. And the person who can fix a machine for ventilation, on the other hand, probably won't know how deep into the abdominal cavity he can stick his hands in, if I say it literally. So it depends. If you want to work manually and you want to operate, then I suggest surgery, but expect at least 8 to 10 years of training. And if you want to do coagulation, artificial ventilation, and all this stuff there, hemorrhagic shock, septic shock, work in the emergency department, then I would go for anesthesia, or we have here a specialty called emergency doctor, emergency room doctor. But these doctors don't operate, okay?
Yeah. Perfect. And one more question I have here was from Julie. She says, hello, I'd like to ask, following at the end of the lecture, if in Prague, what are the routines of which hospital trauma patients are brought to? Is it the closest hospital, or are they sometimes brought to further, but rather more specialized hospitals? And are all emergency university hospitals in Prague equally equipped?
Okay, if you don't mind, I'm going to check because I have just recently, we are writing a book and I have mentioned the criteria in my book. So just give me a minute.
Of course.
First of all, before I open the document, the hospitals are not equally equipped. Some hospitals have the status of a trauma center. Some hospitals, and the trauma center should have available neurosurgeon, a cardiosurgeon, a plastic surgeon. This isn't available everywhere. So primarily, for example, if something happens in the fields between Písek and Prague, and it is indicated for transport by helicopter, which it sometimes is, even though the distances here are so small that it takes an hour to get from Písek to Prague before the helicopter gets up, lands, and loads the patient. Maybe the ambulance is often quicker. So, but such a patient with triage positive, it's called, would not be brought to Písek hospital. They would be brought to a trauma center. And if you give me 30 seconds, I will find the document because I was working on it yesterday. It's usually patients where the one of the persons in the car is dead. It is high velocity, high height accident. Just a second, I will find it here. It was a bit difficult to find the definition because it wasn't, they call triage positive patients. And it would be interesting to see how it would be in your country. So, all right, so. Okay, triage positive. Patient with Glasgow Coma Scale less than 13, pressure less than 90, systolic, breathing frequency less than 10 or more than 29 per minute, penetrating trauma of head, thorax, and abdomen. So the patient that you saw with the rod that would be brought to a trauma center, unstable thorax, flail chest, unstable pelvis, the fracture of 2 or more long bones, height, fall of height 6 meters, run over by a vehicle, which the guy that you saw with a tractor in the field, that would be taken to trauma center. Vehicle speed more than 35 kilometers per hour, thrown out of the vehicle, or stuck in the vehicle, and the death of a person in the vehicle. These are triage positive factors, and such a patient should be brought to a trauma center.
Perfect, thank you so much. We have one more question. The question reads, I want to ask if there was pressure put on you from being a woman in surgery from male doctors.
Okay, this is a very popular question. I get this question in every lecture. And actually, I was just contacted today by a female surgeon in Prague hospital, teaching hospital. They want to start women's section in the surgical society. I didn't feel any pressure because all of my chiefs of surgeon, I had 3 superiors, were very fair people. It was a lot of hard work. I have a daughter and I'm divorced because my marriage didn't withstand my job, but it was me who chose to divorce, so I can't blame surgery. And I think my life was, surgical life was not very difficult because for me it's a passion. So I didn't have a problem spending my extra free time in the hospital. And I think what the male colleagues appreciate most is I work with them. That means I ask for no exceptions, and I I don't want to make it sound like gender bias, but I think what they're a bit allergic to is sometimes the women have a tendency to do other things than surgery. I've had a few girls here, and most of them have had other things. One wanted to be a sports doctor, one wanted to work with the ambulance service, one was a teacher in the second faculty. And I think surgery is a full-time job. And the guys, they're very focused, like they go out of the cave and they hunt for the mammoth. And the women, they tend to do a lot of things around. And then the guys don't really appreciate it when they're doing a lot of things around, and then the girls feel a bit upset because they don't get the same opportunities. So I didn't feel biased at all. I don't think somebody was unfair to me, but it was for a price. I asked for no exceptions, and I didn't do, I know I can't do anything else. I don't play any instruments. I don't do any sports. I have, the only thing I care about is my daughter, and I have very little time to travel. I'm not sad. I'm very happy because this job is a passion for me. So, and I had parents who helped me a lot, which is also necessary. You need help. And I see that Pan Dr. Janovic wrote a comment that gender can't become a factor at work. Of course, we want things that we want, but sometimes reality is different. What I think is best, if I don't agree with any quotas, you have to employ 50% women, because some women don't want to do it. But what's fine is if the community or the work community, the work group is mixed, because men and women, they complement each other. So I employ girls as well, and I try and make use of their qualities, and I employ boys as well. And it's not whether it's a boy or girl, I just try and give them work that suits them and that they enjoy. So, and it doesn't matter if they're men or women. So women are better at some things and men are better at other things. But girls actually are very, very, they have fine motor skills. So a woman can be a very good surgeon. Usually when they leave because they want to. I don't really think they leave because they're, and we have fair lists of who does what surgeries. That means I make statistics, and if I see somebody's done less cholecystectomy, and it doesn't matter if it's a boy or girl, I say, okay, you should practice more of this. On the other hand, if the girl is traveling around the world with the Czech women's football team, then she can't do cholecystectomies. And that happens sometimes, because they have a lot of things they want to do around. So then I tell her, well, I'm sorry, but you can't have 30 cholecystectomies per year if you're not here for 2 months, But that's just like my personal local experience.
Yeah, definitely. And there was one more question a little bit higher up the chat. It reads, how much fluid is safe to drain by chest tube to prevent re-expanding lung edema? By Joanna.
How much fluid is safe to drain through the chest tube? Well, if it's a hematoma, or if it's not coaguli, it's already after, it's not blood that's coagulated. We drain the whole whole thoracic cavity. What we do is we don't give suction too high. All right, we don't, I've seen some of my colleagues, we don't do that anymore. They put full power suction. We don't do that. It's progressive. That means we put 10 to 15 millimeters and slowly. Okay, it's not like full throttle. So slowly, it's a prevention of the edema. You can't expect, to put full power. So it's not a matter of liquid; it's a matter of the suction, and we leave it to drain naturally, if that's the right word that I can use.
Thank you so much. I don't know if there's any further questions of other people in the chat. Feel free to leave them in the chat box or message them directly to me. We're getting a lot of thank yous. Honestly, it was a very interesting and very informative lecture. It's always very nice to hear from you. Last time I attended your lecture in the role models in medicine, I was just in the part of the audience, and it was honestly super inspiring. And I really like the pragmatic view you have concerning the reality of, I guess, gender bias in our area field of work, I guess. Maybe what I could do is really quick. I will share my screen and inform everyone about our future lectures in case someone is interested in joining anything else. I will just, 1 second.
Well, thank you very much. The positive commentaries are very, very nice. I appreciate it. It makes me happy. On the other hand, negative commentaries are also necessary, because without negative feedback, we can't become better. So if you're not happy with something, or you just feel free to write it, and I can, I tried to enlighten you, so you can enlighten me as well, because of course I don't know everything. So. And if you, I would appreciate if it's possible, then maybe to give me back, if you have some written, you said some forms or something.
Of course, yeah.
The surgeon has to be humble and realize that he doesn't do everything right all the time, and that he has to think about his mistakes. So whatever negative commentaries you have, don't worry, it won't hurt my feelings. It will make me become better.
Definitely, I will make sure that we will send you the feedback form results as soon as we have everyone fill them in. Of course, the link is in the chat. I will put it again just in case someone hasn't seen it yet. Please, we're using this new system now where all of your certificates of attendance will be located within the same software. So it would be easier for you to first create an account, sign in, and then fill the form afterwards. But back to our calendar, our future events. We have a few events planned for the month of May. As you can see, the first one will be common conditions in skin of color. So it's a very interesting and not that spoken about topic, how to localize some signs that happen with people of darker skin color. And then we have a few sort of seminars, such as the Cultivating Wellbeing During Exams and Cultivating Compassion in Medicine, and our big final event, which is the Battle of Specialties. I would highly encourage you to follow us on our social media for further updates and, let's say, insights as to what our final event will be. But yeah, this is all from me. We can check in the chat box if there's anything else. I think it's just comments. I guess we can close the call then. Thank you so much for your time, Dr. Horáková. It was great to have you. Always a pleasure for us to host you. Your events and your talks are always super, like with high attendance. So it's great to have you again.
Thank you very much. It was a pleasure.
Okay, thank you everyone, and we will see you in our next events. Have a great week and month and exams if you're a student. Bye-bye.